Good morning to all of you. A warm welcome to our Zoom webinar organized by GMOA Sri Knowledge Academy. Today our lecture is going to be on interpretation of common chest X-ray findings in OPD setup. Kindly mute your microphones and turn off your cameras during the presentation and use the chat box to clear your doubts at the end of the presentation. Now it's my pleasure to introduce our presenter, Dr. Eranga Ganewatta, consultant radiologist currently attached to Lady Ritchie Hospital, Colombo. Over to you, sir.
Good morning. First of all, let me thank GMO and Sri for inviting me to deliver this lecture. And it's overwhelming to see more than 400 people who was joining to this lecture. So basically, I'll be going through some of the basic interpretation of chest X-rays, and I'll be just touching of some of the anatomy, what are the technical aspects that you need to know, and few of the common presentations in the OPD settings that you will be able to recognize and easily diagnose without the help of a radiologist. Hold on. Yeah. Okay. As a general principle, you need to have a systematic approach to tackle an X-ray, though it looks very simple on appearance, but it's very difficult sometimes to interpret any subtle changes. So interpret a chest X-ray always in conjunction with a clinical finding. Always, if you are lucky, you can always compare a previous chest X-ray if available, and make sure that does your interpretation make any sense as a clinical diagnosis. So before we start, it's all about X-ray. It's all about black and white because it uses chest X-ray to penetrate your body and get an image. So it will be either black or white, and you will have some densities in between. And usually there's a relative hierarchy of densities in chest X-rays, or for that matter, any X-ray in the body. So the gas would be the least resistance for X-ray penetration, which will appear as dark, and the metal would be the most resistant for X-ray penetration, which will appear very, very bright white. So in between you have fat, which has a slightly less gas penetration than gas. So we'll have a slightly lighter, darker shade, and then you have soft tissues and bone in between. So any chest X-ray, before interpretation, you need to have some basic idea. First and foremost, you have to identify the correct patient, and patient details identification is utmost important. As well as you need to put up in a well illuminated illuminator rather than handing it over to the ceiling or ceiling light and interpreting, which will lead you into trouble. And always try to recognize whether it's a PA or APV, which is very important, especially if you are interpreting whether you are interpreting the size of the heart. And then you have to recognize whether it's adequately exposed or with an adequate inspiration or expiration, which makes some of the subtle changes which might you interpret as abnormality, it's rather technical faults. And then most importantly, you have to know whether it's rotated or not. Okay, what are the four major views that you do in chest X-ray in an OPD setting? Would be posterior anterior view, which is the PA view. It's the standard for any adult who can stand or hold his breath for a while and who can stand, or ambulatory patient. And the next common would be the lateral, because in X-rays, it's a cardinal rule that you at least have two X-rays to have a complete diagnosis, which is not really happening at the old time. But if you're in a doubt, you always have a second image to compare and come to a diagnosis. And the anteroposterior, which is the most common X-rays that are being taken in children who can't be standing up for a chest X-ray, and patients who are very ill and who can't stand also will be having in ICU settings as well anteroposterior view. And then it comes to the lateral decubitors, which are very limited nowadays, because we in old days, that when dengue came initially, we used to do lateral decubitors, right lateral decubitors, to see very subtle effusions which we can't detect on just a standard X-ray views. If you are thinking of a small effusion, you might do it, but nowadays when you have freely available ultrasound, we usually diagnose these things with ultrasound than X-ray. So this is just to show what a normal X-ray looks like. This is a PAV. You can see in the center the trachea and the mediastinum. Then you in both sides you have the lungs and then the bone and the soft tissues around it. And make sure that you will identify whether it's a female or a male patient, because overhanging breast shadows might give a false alarming that you might be dealing with a small pathology in the lower zones. It's just because of the overlying breast shadows. So I will just touch briefly on the basic anatomy of a AP view and a lateral view, just to make sure that you will be in line when you come to the diagnosis of pathology. So this is the things that you will be able to identify in an AP view. So the number one is the trachea. It comes down and divided into right and main bronchus. The right bronchus is more straighter than the left. So in children and adults, if you have a foreign body going in, it's most likely going into the right main bronchus. And then it comes to the left hilum, where you have number 4 is the left main pulmonary artery. On the right, you have the right upper lobe pulmonary artery. Then you have the interlobar artery, and the number 7 is the right pulmonary vein. This is the hilum on the right side, and this is the hilum on the left side. And then it comes to the number 8, this is the aortic arch. Then you have on the right side, there's a what you call the right paratracheal stripe, which is mainly occupied by the SVC. If you have a pathology, you will have a density over here, which we call the widening of the right paratracheal stripe. And number 10 is where you have the azygous vein coming and arching over the right main bronchus to drain into the SVC. So these are the main things that you can see in the mediastinum. And then you have the lung fields, the right heart border, which is mainly formed by the right atria. Right ventricle is a more anterior thing. So the right border is mainly outlined by the right atrium, and the left ventricle you have the outline, the left heart border, and the left atrial appendage come somewhere here, where you have widening, especially in mitral stenosis. And then you have both the scapula, clavicle, first ribs, and all the ribs you can be able to count. So in a good inspiratory film, in a PA view, at least six anterior ribs and 10 posterior ribs should be able to count above the diaphragms. So that is a good inspiratory film. And when it comes to rotation, you see the distance between the medial end of the clavicle to the spinous processes. So if you have equidistance from each medial end of the clavicles, that means it's a well exposed non-rotated X-ray film. And once you do all these in a chest X-ray, you always make sure that you see for the 4 corners of the chest X-ray, because you might be able to deal with a small extrathoracic pathology when you don't have a pathology inside the chest. Okay, and then it comes to the lateral view. You always can see a lot of things on the lateral view. The center is big busy, but you have these 2 areas which are called the uh, retrosternal space and the retrocardiac space, which usually have a equal density of radiolucency because of the lungs, but the rest of the mediastinum are a little bit busy. For the beginners would be a bit difficult to identify the structures in the mediastinum, but if you see that basically what you have is the trachea in the center, then you have the bronchus intermedius, and you have the left and right upper lobe bronchi, and on the anterior and posterior you have the left pulmonary artery, anteriorly you have the right pulmonary artery. So basically you have to identify the trachea, two lucencies and two opacities on either side. So if you find something more than these things, so you have to think of something like a lymphadenopathy in the hilum. So you have to always, you just don't interpret a lateral film alone. You have to go with a AP or a PAV to comparisons. What are your findings in the lateral film? So the number two is bronchus intermedius, left and right upper bronchus, or left pulmonary artery, right pulmonary artery. This is the confluence of the pulmonary veins. Then you have the aortic arch, SVC. The anterior border is here, is the right ventricle, and posteriorly you have the left atrium. Inferiorly you have the left ventricle. So you don't see any right atrium here because it's a more right-sided structure in the real anatomy. And then you have the two diaphragms. How do you identify the two diaphragms? It's quite easy on a lateral film. So what you have to do is you trace the diaphragmatic outline anteriorly. So if you can go beyond the hard border, that means the outline goes nicely more anteriorly than the hard border, that is the right, which is the higher one, and the left one will be smudging with the hard border. So we'll just trace it up to the heart, maybe a little further up, but it doesn't really go into the anterior chest wall. And the both on the level of the diaphragm, which is normally is the right and the left is bit lower. That is because the left is pushed down by the heart. So I hope that you have understood what are the basic structures that you will be identifying on the AP and a lateral view of a chest X-ray. So what is your systemic approach? There are certain ways of interpreting a chest X-ray. In old days that we used to do is we start either from the center and go into the laterally, or you can start laterally and come into the center. Now they have like described in A B C D E F G H approach, where you start with the airway, then the bones and soft tissues, cardia, diaphragm, effusions, if at all, if there's any effusions, then you move on to the lung fields and look for the gastric air bubble, especially in children, whether it's missing or you can see, and then you describe about what's happening in the hila, or and then you come to a diagnosis. So if you go in an order, so whatever makes it easy for you, you can do it, but you have to go in an order. Don't jump in to different fields in the between, then you will come to a standstill and it will be very hard for you to diagnose. So always make your own way of diagnosing and interpreting a chest X-ray, but you always follow the same methodology in every chest X-ray. So a bit about lobe anatomy. If you look at the right upper lobe, it's above the horizontal fissure, and in the lateral film, it's above the horizontal fissure and anterior to the oblique fissure. When it comes to the right middle lobe, it's joining the right hard border. Always remember the right hard border is outlined by the right middle lobe, and it's below the horizontal fissure and anterior to the oblique fissure on the right side. And the right lower lobe, it's always outline the right diaphragm, and it goes fairly higher up. So any pathology in the superior segment of the right lower lobe could be misinterpreted as a lesion in the upper lobe, but if you do a lateral, you will be able to see that it's posterior to the oblique fissure, and then you will be able to safely diagnose it's in the right lower lobe, not in the right upper lobe. When it comes to the left side, it's just two lobes. So you have an upper lobe and a lower lobe. So when it comes to the upper lobe, it's anterior and it's anterior to the oblique fissure, and posterior is posterior to the oblique fissure. But again, you can see that the superior segments always overlap the upper lobe. So moving into some of the pathologies, this is kind of a very common presentation in an OPD setting. A adult patient coming with breathlessness, and you do a chest X-ray, so you will find this. So what do you think you have here? So it's basically, if you go in order, you see the airway quite central, but it looks like a bit of a rotated X-ray. But then it comes to cardiac outline is obscured, and then you see the diaphragms, which are both obscured in this. So something going on in the both lower lobes, and then you have in the lung fields, you have only the upper lobes you can be seen. So, and with the meniscal sign, this is a bilateral pleural effusion with a large effusion on the right side. But if you look at the mediastinum, like taking into the consideration that there's a bit of a rotation, there is not much of a movement of the mediastinum. That means even though you have a very large space occupying fluid in the right side, there is not much of a movement to the other side. That does mean it is accompanied with some part of a collapse to accommodate the fluid in this area. That means it has compensated by collapsing some part of the lung. So that is why there is no real movement of the mediastinum. So this is bilateral pleural effusion with associated segmental collapse or lower lobe collapse on the right side, with larger effusion on the right side. Another common presentation, this is a young patient presented with the RTA, and if you look at this, there is an obvious abnormality on the right side, and again, it's a rotated film. As you can see, it's a fairly ill patient, so the imaging would be a PAV rather than an APV. It's a APV rather than a PAV, so he should be on a bed and on a stretcher, must have taken straight from the APV, and you can see gross abnormality on the right side. So what are the abnormalities you will be able to see? There are multiple rib fractures. You just count from anterior to the posterior, and then you can see there's a disruption on this side. And when you find a rib fracture, you always make sure whether at least one rib is fractures in two segments. So then you will end up in a flyal chest. So if you see a fracture, just don't say it's fracture. Try and identify whether it's fractured at both, like two segments. And then you have something going on these soft tissues, which is not as clear as on the left side. So if you look at, it's like a streaky air lucency is going everywhere in this subcutaneous tissue. So this is surgical emphysema because of the fractures and rib fractures and lung contusion. And if you look at the lung, it's more radio opaque than the normal side on the left side. So there is element of lung contusion, multiple rib fractures, and subcutaneous emphysema. So this is how you would be able to interpret and see. And there is not much of a mediastinum shift. You can't see a lung outline. So there is no real threat at this moment for the life. And there is no much of a pneumothorax on that side either. Okay. And moving on to another common presentation. And then what you see is, again, the trachea is very central, mediastinum is central, cardiac outline is quite okay. Still, you can't see much of the left cardiac border. There is something going on the left side. Left diaphragm is little flattened. The costophrenic angle is there, but still the line is little flatter than usual. And on the right side, fairly good lung markings. You can trace it up to the chest wall. There is good costophrenic angle. Ribs looks fine. And when it comes to the left side, there is hyperlucency with absence of lung markings. These are the usual lung markings that you can see, which is absent on the left side. And there is minimal, if at all, there's a mediastinal shift to the left side. But when you comes to this huge amount of translucency on this side, this is a fairly big pneumothorax without much of mediastinal shift. So you call it a pneumothorax. This could be either spontaneous or traumatic, but doesn't look like a traumatic. You don't see any rib fractures here. So it can be an isolated idiopathic pneumothorax without mediastinal. So it's a simple pneumothorax. Okay. Here again, it's a pneumothorax. You can see the NG tubes and the mediastinum is completely distorted and shifted towards the right side. And you can see there's a hyperlucency on the left side. As you can see in the previous one, there is significant shifting of the mediastinum. And this is an emergency. You don't need to wait for a surgical registrar or a SHO to come and help you with this. If you diagnose it, you need to immediately needle decompress on the left side, otherwise patient will have hypotension and will collapse. So this is a medical emergency, and if you see it, you don't have to wait for anybody. You just put a small large bore needle between the second and third ribs anteriorly to needle decompress. This is a tension pneumothorax. Again, so if you come to this x-ray, when you see, you go in again in the systematic way. Airway looks fine, cardiac outline is fairly smudged but looks okay. There are multiple shadows on both sides, and you can always see a tube line going in this. This is a IC tube, and if you look carefully, you can't trace this the lung markings up to the chest wall superiorly. So even with this IC tube, there is a residual small pneumothorax in the anterior, more superiorly on the right side. So patient would have had a large pneumothorax. They have inserted IC tube with a residual small pneumothorax on superiorly. So when you're interpreting x-rays, if you see any lines, just go through the lines first. These are the ECG leads, you can easily see, and then you can see the IC tube coming from the right side to drain it. So always when you put IC tube, it has to go directed superiorly if you are draining a pneumothorax, and if you're draining a hemothorax or pleural effusion, it should direct, because it's all about gravity and dependency of the content that you are going to drain. So there's no mediastinal shift. The trachea is central. So it's not a retention pneumothorax anyway, because of you already have IC tube. This is just a residual small pneumothorax. And make sure that if you can't see a pneumothorax on a standard one, but you're highly suspecting, it's always better to take an expiratory film. The expiratory film will be accentuate whatever the pneumothorax you have, and it will be easy for diagnosis. Or else you can take a lateral decubitus film also. Okay. Again, another common presentation that you will come across in OPD setting. Again, go in a systematic manner. You will see the it's fairly equidistant from the center. So it's technically it's a sound chest X-ray, PAV, not rotated. You have a bit of scarring in both APCs, but when you come to cardiac, you can see it's fairly good, but there is a you see some part of the cardiac board on the right side which is not there, and it has shifted toward the left side. So when you have a mediastinal shift, there are two things that you need to consider. Either the mediastinum shifted into that side because there's a volume loss on that side, or there's something on the other side which is space occupying. So if you look at the right lung, it's very good. You don't see anything space occupying. So something going on the left side. So when you look carefully, you don't see any major problems in the lungs. But if you can see, there's a triangular shape opacity in the retrocardiac space. So this is what you can see, and the outline of the diaphragm also not that clear what you usually see in a normal chest x-ray. So this is a left lower lobe collapse that you will see as a triangular sign in the retrocardiac space. So always make sure that if you see something it's normal, then you always have to look the retrocardiac area also to make sure that the before you call it a normal chest x-ray. Or similar changes on the other side. So when you again see that there's a mediastinal shift towards the left side, this looks like a patient who's critically ill. You have IC tubes, you have a line coming from the arm, which these are called what you call the peripherally inserted central line or PIC lines, not a central line. Central line would be coming from here in the neck. This is coming from the arm. So these are peripherally inserted central line. You have a tracheostomy tube, you have IC tube. So patient should be a critically ill patient, maybe after surgery. And you can see there is the right diaphragm is not seen. There is volume loss, mediastinum shift to the right side with the obscuring of the right outline, right diaphragm. So if you look at the lobe anatomy, so what is um, outlining the right diaphragm? It's the right lower lobe. So you can't see the right diaphragm. So this is right lower lobe collapse, and you can make note of that. You can still see the right cardiac border. That means the right cardiac border is intact. That is, right middle lobe is not having any pathology. It's just the right lower lobe. Okay, another common scenario, maybe not that common, but in adult, you always have to have, if it is adequately taken, a chest x-ray without any rotation, and if you see both lung fields, you can see there's some opacity on the, but it's a diffuse opacity, but you call it a veil-like opacity on the left side. And you always compare with the right side, other side, then you can see there's a veil-like opacity. There's elevation of the diaphragm, but the outline is intact. The cardiac border is fairly okay, but still it's smudged, and there is sharper outline of the aortic knuckle as well. So this is what you call the left upper lobe collapse with veil sign. So always make sure there's a evidence of volume loss, and there is diffuse volume loss on the left side with elevation of the diaphragm, but the outline is maintained, and you call it a left upper lobe collapse. Here you make sure that there's not significant mediastinal shift because of the hyperexpansion of the residual left lower lobe, which occupies the whatever the collapse area. That's why you get the elevation of the left hemidiaphragm. When it comes to the other side, you have a this is a very common scenario in adult smokers, where you get an upper lobe collapse because of the some sort of a bronchial obstruction, mainly tumors, bronchial carcinoma. Then you can see that the right horizontal fissure has elevated. There's opacity in the right apices, and the right cardiac border and the diaphragm is intact. And this is what you call right upper lobe collapse. And if you have a tumor here, you will have a reverse S sign. So you call it a golden S sign, and it's quite, unless proven otherwise, it's because of a large bronchial mass obstructing the right upper lobe bronchus. This is upper lobe collapse. So when you come to the middle lobe collapse, it's more subtle. And if you look at the anterior waves, it's very subtle. Uh, Maybe it's easily missed in most of the instances. And if you see, there is some obscuring of the right cardiac border, which has to be a sharp edge, which is outlined by uh, the right middle lobe. But if you do a lateral, and it's quite easy for you to diagnose that the right middle lobe has collapsed. But the same patient, the AP view or the PA view is not that obvious. But if you look carefully, and patients coming with some symptoms, and if you have to suspect there's something going on in the right middle lobe, and take a lateral, which will easily confirm there's a right middle lobe collapse. Okay, these are what you call the whiteout of a single lung. So here, if you go to the airway, you can see that it's clearly rotated and it's clearly shifting towards the affected side. That means there's a significant volume loss without any mass effect on the other side. So it's a fairly big opacity with volume loss and mediastinum shifting towards that. This is called lung collapse because there is volume loss, opacity, only minimal amount of residual air is there with the mediastinal shifting towards the affected side, which means there is volume loss in the affected side. There's a large lung collapse on the right side with fairly hyperinflated or the compensatory hyperinflation, and you can see the flattening of the left diaphragm. That is because of the to maintain the oxygenation, the people try to overcompensate and hyperinflate on the normal side. And even if you see this in an adult, you have to think of a tumor always, and if it is in a child, you have to think of a foreign body or mucus plugging also can have the same effect. Similar scenario, but it looks like patient is critically ill and the mediastinum is shift. There's white out of the lung on the left side, but mediastinum has shifted towards the opposite side. And if you can see, there are a few lines. There's IC tube coming in, have a bit of a pneumothorax, the surgical emphysema, and there are multiple rib fractures. So obviously the patient had a traumatic event, and there is some gas leaking into the subcutaneous tissues, but there is whiteout with small aeration of the residual lung on the right side, left side, with mediastinum shifting to the opposite side. That means whatever the pathology here is a space occupying, and it's shifting the mediastinum away. So it's a traumatic patient, critically ill. It's a large, massive hemothorax on the affected side. So you need to be drained immediately to have adequate expansion of the affected side lung. Again, another opacity which is just confined to some area, and if you can see, there's a clear demarcation horizontally. That is because of the horizontal fissure, and then you can see some dilated bronchi, or not really dilated, air within the bronchi. So that is opacity with bronchi going into the affected area. That means the bronchi are patent, and this is what you call the air bronchogram in a consolidation, and it's confined by a fissure. So it is in the upper lobe consolidation where the bronchi are not affected. So if it is a collapse, then it has to be, the bronchus should be affected, and you will be seeing the air bronchogram within. Another x-ray looks like patient is critically ill. Patient is having a IC tube as well, but if you look at the x-ray, it's fairly poor quality x-ray because of the PA, and probably a mobile x-ray taken because of the nature of the illness. And if you look at the chest x-ray, you can see the heart is quite normal, airway is good, diaphragms are outlined good. The chest x-ray is APV, but fairly aeration appears good. There are the densities on the either side which are quite normal, but if you trace up there are added hypodensities in both uh, apical regions superior to the lung, and it's lower in the neck, soft tissues. This is again a patient who had a difficult intubation, and traumatic intubation has ended up in having surgical emphysema. So any chest x-ray that you have looks normal. Make sure before you say normal, look at the four corners and make sure that nothing happening in the lower neck as well. So this is and can be easily missed, and you have to like tell the anesthetists who were looking after, there's some surgical emphysema there in the neck. Again, chest x-ray is not all about just chest x-ray findings, and if you look at this, chest x-ray looks fairly normal. There's a bit of rib crowding on the left side, maybe there's something happening there, but if you look at under the diaphragm, there is clearly gas under the diaphragm. So when you do a chest x-ray, if it looks normal, having some symptoms, can't explain, and if you make sure that you don't miss any gas under the diaphragm, which is quite uh, maybe you need to alert the surgical team that the patient has some hollow viscous perforation in the abdomen, and you need some surgical intervention or in further imaging with CT just to identify what's happening in the abdomen. So if you do a chest x-ray, make sure that you don't see any gas under the diaphragm, and especially in children, you need to see the gastric air bubble on the left side. If it is just a neonate who has just born, to make sure there is no esophageal atresia, something like that. Another common chest X-ray finding that you will come across in OPD setting, adult patients who comes with SOB, worsening SOB over years, and who had some other underlying pathology, who has been on some treatment for other pathologies, which you will see the interseptal thickening, and there are multiple fibrotic changes. If you can see that, not really a volume loss, but you can see that interstitial thickening is there, not filling the airways here, but the interstitium is thickened. The You can see there are streaky lines everywhere in the lung without any predominance. So there are various ways of finding out which are the type of fibrosis. But if you look at this, there is diffuse changes on both lung fields with streaky shadows, with thickening of the interstitium, not the alveoli, not the air spaces here. So it's interstitial pathology here. And if you do diffuse thickening like this and a chronic SOB, it's lung fibrosis. Another common scenario in this part of the world, you can have patients who are coming with chronic cough, and then you will be seeing some irregular or regular cystic lesion on one side of the lung, which is a cavity. So when it comes to a cavity, there are a few things that you need to notify. One thing is the wall. If the wall is regular and thin, it's likely to be a benign cyst. But if it is irregular, thickened cyst, then it has to likely to be a pathology like a cavitated neoplasm. And then if you have a cavity, then you have to see whether there's a fluid level. So if you have a fluid level, that could be affected or infected cavity with the air fluid level, or it could be even an abscess. And then if you have a chronic changes of the lung and you have a filling defect within the not really a filling defect, it's opacity within the cavities, which is a common finding again in this part of the world. That is a mycetoma secondary to TB cavity, and patient could be having multiple episodes of hemoptysis. Okay. Okay, this is, if you look at this X-ray, it's obviously that it's abnormal. And if you see what are the abnormalities, they are well defined rounded nodules involving all parts of the lung. And if you can see that they are well defined, the line looks very uh, nicely outlined without any speculations, and they are distributed all over the lung field. This is full-blown pulmonary metastasis. This is common. There are few primaries that you will, especially bone tumors, that you will end up with like this, and you have to immediately think of something happening, whether the patient has a known primary, or if not, if it is the first presentation, then you have to look for primary of any kind to have pulmonary metastasis. So it makes sure that when you comes to pulmonary metastasis, they are well defined, usually peripherally, and low predilection is the usual scenario to have pulmonary mets. Okay, quite similar to the old X-ray, but here when it comes, there are multiple opacities with irregular outline, speculation. But this is can't be a malignancy because it's involving both lungs. Similarly, which is very rare for a malignancy to happen that like that. And if it is ill-defined, this is what you call an atypical infection involving both lung fields, likely fungal infection or atypical pneumonia. So similar to the old one, but the changes are irregular and haphazardly distributed with opacities of the pulmonary lung. That means it's an infection going in the airspace for pacification. You will call it a atypical pneumonia or a fungal infection. Uh, this is a very subtle changes, but it's very important. So you go again according to the outline. You see the airway looks fine. Then you see the bones and the soft tissues looks fine. Then you come to the cardiac. What is the usual cardiac size is less than the zero point 0.5. So you get the widest diameter of the intrathoracic distance, and you get the widest diameter from the center to the either side and add both to get the cardiac diameter. It should be less than 50% of the intrathoracic diameter. So it's fairly big heart. That means that there is cardiomegaly. And if you look at the what's happening in the chest X-ray, you will see that there is little bit more added opacities, and there are few tiny lines going up to the chest wall. So usually the pulmonary, you have three segments like medial, intermediate, and lateral. So usually these pulmonary shadows should be like reduce in intensity when it goes out to the chest wall. But here you can trace it up to the chest wall, and there are tiny lines which are called interstitial septal thickening or curly B lines. These are what you call curly B line. You have cardiomegaly, curly B lines, then you have the prominence of the upper lobe vessels. Why are these upper lobe vessels are usually not prominent? Because of the gravity. When you stand in up position, because of the gravity, the lower lobe, the pulmonary arteries are more prominent than the upper lobe. But when it comes to the pulmonary edema, because of the pressure difference, the upper lobe arteries also becomes more prominent. So this is called upper lobe blood diversion. And there are things called peribronchial cuffing. If you can see this X-ray, there are thickening of around the bronchi. This is because of the interstitial edema. And these are also interstitial edema. This is peribronchial cuffing, dilated upper lobe. And if you look at the hard border on the costophrenic angle on the left side, there is blunting and there is element of a small effusion. Right side fairly okay, but if you look at the left side, there is a small effusion. There is alveolar edema, cardiomegaly, curly B lines, and upper lobe blood diversion. This is what you call the patient with typical heart failure features. And though looks at a glance, it looks really a normal chest X-ray, but if you look it into detail and looking at the scenario, if you can see the patient looks fairly ill with all the monitoring going on, even with that. And if you always like have to tally with the clinical finding of these patients, and this is a typical X-ray that you will come across with heart failure. Another chest X-ray. So when it comes to mediastinum, there are certain pathologies. I wouldn't be going into more detailed pathologies, but if you just brief something about it, then when it comes to the heart, it looks very, very big. So either it could be a enlarged heart, and if you look at the outline of the heart, if you look at this is also cardiomegaly, but the outline doesn't look that sharp. But here, if you look at the heart border, you can see that the outline is very, very much clear. So when you have the outline, you have the pericardium. Usually the heart is a mobile structure, which is having all the contractions, because it's not a static structure. Usually you don't get a very clear outline because of the multiple contractions during the X-ray excision. But if something is happening there and slowing down, or the movement of the cardiac contraction is not pulsated up to the pericardium, then you will get having this very sharp edge of the heart. When you have a globular shaped heart with a very sharp outline, this patient we have to suspect of having a pericardial effusion. So that's how you diagnose a pericardial effusion. If you have a very enlarged heart, either it could be a pericardial effusion or a cardiomegaly, and then you look at the cardiac outline. If it is very sharp and clear, then you would have to suspect a pericardial effusion, and you might need to call for a echo and see what's happening with the patient. Okay, another mediastinal abnormality. And if you look at what's happening here, you say the airway is quite fine. But if you look at the main bronchi, they are splayed, they are widened. So something going on between the carina and the heart. There's a apparent double shadowing of the heart. There is, if you look at the left heart border, there's widening of the atrial appendage, and this is called left atrial hypertrophy. Right. And in chest x-rays, you might, if you think, you might be able to get these ones also, but very not very common. And if you can see, there is fluid level, retrocardiac shadow, gastric bubble is not very clearly seen, but this is what you call a hiatus hernia with fluid level in the retrocardiac space. So this is due to a hiatus hernia. So I have touched few things on chest x-rays and common findings in chest x-rays, and I hope that you have uh, got some knowledge on interpreting of chest x-rays, and make sure that you always go through in a systematic manner, so you won't be able to, you won't miss the major anomalies. But if you miss a small anomaly, it's always there's the radiologists and the specialized people who look after the x-rays will be there to identify the subtle changes. But you have to go in a systematic manner to identify these the major anomalies that you will come across in day-to-day practice. And thank you very much. And if you have any questions, I'm happy to answer.
Thank you very much, sir, for that very informative presentation. It's time to enlighten few queries. Please write your questions clearly in the chat box. So there's a question: how to identify the pleural effusion?
Pleural effusion is quite easy. You look at the both costophrenic angles. So it's a very sharp edge. If you look at the, no, let me put the normal X-ray first. So this is a normal chest X-ray, and you look at the costophrenic angles, which are very deep, and you can see it's very sharp. So if there's any blunting, you have to suspect pleural effusion. And if you're not sure, you always can have a lateral decubitus to see whether there's any fluid level within.
There's another question, sir. Explain about COVID features in a chest X-ray.
Yeah, they are quite common. The majority will be having normal chest X-rays, and it doesn't really correlate with the the severity of the symptoms of the patient. Some people have very marked changes, but still the saturation and everything maintained. But more or less they correlate together as well. Initially, what you will have, initially you will have curly B lines on the chest X-ray. Then you will have patchy consolidations, or what you called ground glass opacity. That is like a veil-like opacity, but in a patchy peripheral located mainly in the lower lobes. And then with progression, it will be more like consolidations. Then it can go up to ARDS, like diffuse ground glass opacities in the chest X-ray. Full blown pneumonia you will have on both sides, not a particular lower lobe predilection.
Third question: how to check the cardiomegaly in APV?
Yeah. So basic way of doing it, you get to get not a AP view. AP views, you will have apparent cardiomegaly because the heart is away from the X-ray film. So you can't describe about a cardiomegaly in a AP view. But PA view, I will tell you, it's the intrathoracic distance. Then you get the widest diameter of the heart, but it doesn't have to go in a same level. So what you get is from the spinous process to the longest distance on the left side, and widest from the spinous process into the right side. You add on those two and divided it with the intrathoracic uh, distance, which is called the cardiothoracic ratio, which is less than 50%. That can be done only in a PA view, not a AP view. AP views, anyway, you will have some sort of a apparent cardiomegaly because it's away from the X-ray film.
Next question: how to identify AP from PAV?
Yeah. So whatever the structures which are very close to the X-ray will be very sharp. So in a PAV, the anterior structures will be very sharp, while the posterior ones are, which are not that uh, sharp. That is one thing. And the heart will be not as like this, it will be little wider. And then you can see, look at the scapulas. If you see the PA waves, the scapula is always away from the chest field, but AP wave, it will be overlying the upper part of the chest, and always there will be a uh, marker saying whether it's a AP or a PA view. That is a usual uh, norm to put a what type of a X-ray to be seen.
There's another question, sir. How to differentiate airspace opacity and interstitial opacity?
Yeah, so that's a good question. The airspace opacification will be more profuse and larger, whereas interstitial opacification will be linear because it's between the pulmon, like the it will be between the bronchi, and then it will be between the alveoli as well. So it will be, won't be a coalescive, a large if changes you won't be able to see in uh, interstitial opacities, whereas pulmonary opacifications you will have like a consolidation. So it will be like a large area of confluence opacification. You will see it in pulmonary opacification, but in interstitial you will have a linear and tracking towards the high, the mediastinum. So it will be linear patchy opacification in interstitial opacifications.
Can we see fluid behind cardiac shadow in Barrett esophagus?
Yes, yes. So in not really in Barrett's, but sometimes you will see, especially in achalasia cardia, you will see a very large opacity in the retrocardiac space with fluid levels, especially in achalasia. Barrett's also, of course, you might get, but it depends on the type of Barrett's and the level of obstruction there.
How to identify the curly B lines?
Curly B lines are the interstitial lines which are coming from the edge of the, so I showed you earlier also, it's coming from the chest wall horizontally on the more lateral, the from the chest wall towards the lung. Those are the curly B lines. Those are interstitial fluid in periphery. Especially you will see it in heart failure.
How to check for penetration and exposure in chest X-ray?
Yeah, that's a good session. I didn't touch because the sake of time. Exposure, you have to have the faintly the lower chest X-ray should be able to visualize the lower vertebra faintly, not very prominent. That is how you chest X-ray, and then you have to have see the pulmonary vasculature up to the middle third without any pathology up to the middle third of the lung. These lung markings should be able to see, and you should be able to see the uh, vertebra below the behind the heart faintly, like in this X-ray, not very prominent. If it is very well prominent, that means it's over penetrated. If you don't see anything at all, that means it's under penetrated.
We have few more questions, sir.
Yeah,
Can I
sure.
continue? Can you please explain again how to identify pneumothorax?
Pneumothorax, it's very easy. So what you have to do, there are two things to identify pneumothorax. One thing is to identify uh, lung marking. So if you see here, if you can see that there's a edge here, and then other thing is you have to trace the lung marking up to the lateral chest wall. So here you can see up to here, you can trace, but these markings are get less prominent as you go into the lateral, but still you can see up to this level. But if you here see here, the lung markings stops at here. So that is the two ways of identifying the pneumothorax. You have to see a uh, edge of the lung, and you won't be able to trace the lung markings, the vascular markings, not the lung markings, vascular markings up to the chest wall. Those are the main two things that you need to see to identify a pneumothorax. And if you can't identify, you can always get an expiratory film which will accentuate the pneumothorax findings.
So, how do you differentiate interstitial fibrosis and pulmonary edema in a chest X-ray?
It's all about clinical findings, and uh, you have to always, as I said earlier, you have to like go through the clinical scenario first. But if you see the interstitial fibrosis, there won't be any changes in the heart. The heart changes would be minimal. Because of the interstitial, you will have a diffuse changes. Like fibrosis, you will get diffuse changes in the lung without any predilection of the size of the heart or any changes in the pulmonary vasculature. So in pulmonary edema, here you will see that there is interstitial thickening and peribronchovascular thickening as well. These are interstitial thickenings. But if you look at the heart, there won't be any changes, and there won't be upper lobe blood diversion. There won't be any pleural effusions. So as I said, there are certain things that you would see in a heart failure, which will be less or minimal on fibrosis, except for pulmonary interstitial thickenings and these fibrosis volume loss, and you will end up having a loss of volume in chest X-ray, and they are symmetrical, usually symmetrical on both sides.
What is ground glass appearance of a chest X-ray? What are the examples?
Ground glass is, if you think of now, it's commonly the COVID, because you will get ground glass is like a veil like opacity. It's a diffuse opacities in the pulmonary areas. So it's like a ground glass. That means it's like a veil like opacity without any patchy or any you can get patchy opacification, but it will be like a increased density, like a homogeneous increased density rather than consolidations. So ground glass is like increased density of the lung fields. the common finding would be now it's COVID, and there are certain other fear, there are infections, there are certain uh, like pulmonary fibrosis. Initially, you would end up in ground glass, then leading to the fibrosis. Those are the things that you will get.
Is gas under the diaphragm significant when it is on the right side only? How do we differentiate gas under the diaphragm from stomach gas bubble?
No, it it is significant in if you have any side, but if you can't see a gas under them, but you are highly suspicious, you have to take a right lateral decubitous film. That means right is up. So whatever the gas will come up to the most undependent part, that is most higher position. But if you are if you don't do with the left lateral, because then the gastric air bubble can be obscuring the whatever the subtle changes. So if you are not sure, you have to do a lateral decubitous film with right side up to have see whether gas accumulates under the abdominal wall.
Please explain more on reverse S sign, whale sign, and golden sign.
Okay. Whale sign is the left upper lobe collapse. So if you see, when you put a veil, you won't be able to see the bride's face. No, that's the same thing. You don't see much of the opacity goes out, and there is I mean the clarity of that side goes out with the volume loss, elevation of the left heavy diaphragm, and there is like a diffuse homogeneous. This is kind of a ground glass opacity, if you want to really call it. It kind of a ground glass, but it's not ground glass because of the opacity. Then this is like a veil coming over the inflated left lower lobe. So you have the hyperinflation of the left lower lobe, but there is some like a curtain coming over it and having obscuring little bit of the normal penetration. So this is what you call the veil-like opacity, because it's like a curtain. It's collapsed, but it's anterior to the oblique fissure, and it's covering the hyperinflated left lower lobe. Then you will get this uh, this veil-like opacity that is typically seen in left upper lobe collapse. Okay, into the golden S. Golden S is the same thing, or the reverse S, golden S is the same synonym for the same thing. You have to have a mass here. This is just a pure and simple upper lobe collapse. But if when you have a mass, you will have a opacity coming like this and going like this. So that is called the S, or the golden S sign, or reverse S. It's all the same.
In lateral weave, is there anything like left lateral and right lateral to differentiate right and left lungs?
Yes. So when you do a right or left lateral, that whatever the pathology that you are thinking has to be closest to the X-ray image. So if you have a pathology on the left side, you have to do a left lateral. If you have a right lateral pathology, you have to do a right lateral, because you need to have the closest to the X-ray image, where you can have the uh, visualization more clear, and you have to have the pathology more clear to the X-ray, so that you will see a more clear image than the other side.
Our last question, how to differentiate pulmonary metastasis from primary lung tumors?
Yeah, primary lung tumors are, at least if you have, usually it will be a one or two usually. But if you have usually primary would be at one with, you're probably talking about primary lung mass with pulmonary metastasis and just pulmonary metastasis. So the primary lung masses would be a solitary lesion with a irregular. You have a speculated irregular margins on a pulmonary primary. But if it is a metastasis, you will have a very nice clear outline. So those are the two main differentiated, and the number will be very much the numbers are higher in pulmonary mets. And if you have a primary lung, it will be just a solitary lesion. And the main two differentiating point would be the outline of the lung marking. If you have a speculated, it has to be a primary lung mass. If it is well defined, it has to be a metastatic disease.
If there are no more queries, I would like to thank Dr. Eranga Ganewatta for his excellent presentation on behalf of GMO Sri Knowledge Academy. So thank you very much everyone for participating today. So here we are signing off for today. Have a good day. Stay safe and stay home.